Hi, hi. Welcome all to this new video. So the today's topic is NRP, that is Neonatal Resuscitation Program. I have tried to include the recent 9th edition NRP updates which are being given in October 2025. Okay, so NRP doesn't start at birth. NRP starts before birth. So before the birth of the baby, we have to ensure three pre-delivery preparedness. First is the antenatal counseling of the parents or the attendants. We need to explain to the parents or the attendants that what all can be the possible risk factors in the baby, what all requirements may be needed in the baby. Second thing is team briefing. In team briefing, remember three things. First is decide the roles. So there must be a team leader, there must be a person who should be responsible for the ventilation part, then there must be a person who should be responsible for the compression part. Second is the at least one NRP trained individual for each unit. So for multiple deliveries, there must be two persons who are trained in providing complete NRP. Okay. Third important thing is this closed loop communication, potential MCQ. What is closed loop communication in team briefing? It means that the listener has to repeat whatever has been said to him. For example, if I ask whether Dr. Manas, whether the suction is working, so we are supposed to say yes, Dr. X, the suction is working, not just simply saying yes or no. Okay. Third is the equipment check. So equipment should be checked in order of the NRP. Whatever we are going to do in the NRP, we should check the equipments in the same order as it is being advised like this way. Now, one thing is this, the radiant warmer on manual mode. What is this? So all of you must see this warmer in an ICU or in your newborn care corner in the delivery room. This is radiant warmer. So there is a heating filament in the abort and there is radiation heat which will come towards below, and baby is lying here only, you know. So in this radiant warmer there are two types of mode. One is the manual mode, one is the servo mode. Servo mode means that the probe is being attached on the baby and this warmer will adjust the temperature according to the temperature of the baby. And manual mode is that you have set some temperature, for example 36.5, and warmer will give the heat only like 36.5. So before the birth of the baby there is no baby, so the warmer should be kept on the manual mode. Okay. Second thing, there are four pre-delivery questions we have to ensure. What are these questions? First, what is the gestational age of the child? Okay. So second, whether the amniotic fluid is meconium stained or clear. Third, or any additional risk factor. And fourth, we have to decide the management of the umbilical cord with the obstetrician. Okay, these four questions we are going to ask in the obstetrician before the delivery. Now, birth of the baby will take place. Now first update, now as far as previous guidelines, the birth will be directly like in this way, but now we have added one more step, and this is a potential MCQ point. Initial cord based management. What they have said? So they have said that the delayed cord clamping for at least 60 seconds in newborn who do not require immediate resuscitation. Earlier it was 30 to 60 seconds. Now they have changed it to at least 60 seconds. So for those neonates who will not require immediate resuscitation, we are going to do delayed cord clamping for at least 60 seconds. Second is this new umbilical cord minking, and I think that if you are sitting in a competitive exam, this is going to be a very potential MCQ point. Okay. What they have suggested, in neonates from 35 to 42 weeks, like if term or late preterm, milking of the intact umbilical cord is reasonable alternative to early cord clamping in non-vigorous babies even after stimulation. So what it says, like if for example for any child you may not be able to delayed cord clamping and the child is having a term or a late preterm delivery, so milking of the umbilical cord to provide the some amount of excess blood to the baby to prevent the anemia and all the other risk factors is advisable. From 28 to 44 weeks, there is not enough evidence to recommend the umbilical cord milking. Remember the line. And in less than 28 weeks, there is increased risk of IVS. So it is not recommended. All three should be the potential lines. Okay, now the baby is being born, we are going to see three things. First is the whether the gestation is term or not. Second, good tone or not. Third, breathing or crying good adequately or not. So if all three of these are yes, then we are supposed to do the routine care. What is routine care? So routine care is the skin to skin contact with parents. Now earlier there were mother. Earlier the concept was only for mother. Now they have changed it to parents. Then routine care like providing warmth, suction, dry, and then maintain the normal temperature, and then we are going to evaluate the child fully, like there is any congenital defect or anomaly, ongoing evaluation. So suppose what is this is? This is skin to skin contact. You are seeing that the baby is lying on the mother's abdomen. So actually this is known as skin to skin contact, and it provides the thermal protection to the baby. Secondly, actually it increases the bond between the mother and the baby. So it is helpful in the promotion of the breastfeeding also. So there is some three terms like synchronized like this way. So first is like the zero separation like mother and baby to be in skin to skin contact. Then there is something known as rooming in means that mother and baby bed should be nearby. So this is known as rooming in. And now on recent concept that we have developed, it is mother newborn care unit, MNCU. So mother and the baby are being kept in the same room, in the same, even if the baby is being ventilated. If someone wants to read, you can read about this concept. Okay, now third thing, so if there is anything from here is no, then what we are going to do, we are going to do the routine initial steps. First, provide the warmth. You have to take the baby to the manual mode on radiant warmer, and then maintain the normal temperature, warmer पे लेके जाना. Then second is the dry. So dry के लिए there is a technique, 3-stroke technique. First at head and then trunk and then leaves. Okay, and you are going to replace the wet linen from which you have dried the baby, and you are going to cover the baby in the dry linen. Okay. Second is the position. Position means that neck should be slightly extended. This is the position. So how we are going to maintain this position? We are going to have a shoulder roll like a blanket or a towel we are going to make, and this should be like sniffing position of the baby. And then now they have said that stimulation and airway cleaning only if needed, not mandatory. Okay, so how we are going to stimulate? Stimulation is not being done like vigorously tapping the baby back. It should be done by gently rubbing the back or the extremities. And how we are going to clean the airway? We are going to suction. So some important points regarding suction. Okay, suction mouth always followed by nose. Why? It prevents the aspiration if the infant breathes while the nose is being suctioned. Okay. Second thing, suction catheter should be 12 to 14 French, and the pressure of the suction catheter should be less than 100. And do not go too deep up to the pharynx. Why we shouldn't go? Because there is a risk of the vagal stimulation, vagus nerve stimulation, that can lead to bradycardia and apnea. Okay, now coming to this. So when after these initial steps, if the baby is still gasping or apneic, or the heart rate is less than 100, if it is not, so you have to go to other things. So if there is labored breathing or persistent cyanosis, so what happens if there is labored breathing or baby is still cyanosis? You are going to give pulse, you are going to attach it to a pulse oximetry, and then you are going to give oxygen, free flow oxygen, and you can consider CPAP in case of labored breathing. What is the role of CPAP is also important, but we will not go deep into the CPAP. Why? See what CPAP works and what is the action of CPAP. Oh, no. Now, how the target saturation SpO2, what is the target saturation? So earlier 1 minute saturation target was also being given, and now they have removed it. So it starts from the 2 minute, and it also makes sense because in the 1 minute we are going to do the initial steps. Then 1 minute pe pulse oxy laga pana is a difficult thing. Okay, now if there is something apnea or gasping or heart is less than 100, then you are going to do the initial 3 steps. What we are going to do? We are going to give ventilate. Now earlier this was positive pressure ventilation, so now they have removed it to ventilate. Okay, change it to. Second, you are going to give pulse oximetry, and you are going to attach the cardiac monitors also. Now, so earlier positive pressure ventilation and ventilate. So what is the initial starting FiO2? Whatever I am writing in purple is actually the updates in the 9th edition, and so I have maintained the code, and everything in purple is the recent update. So they can be a potential questions. Okay. So initial starting FiO2 is now being changed, like more than or equal to 35 weeks it is 21%, 32 to 34 weeks it is 21 to 30%, and less than 32 weeks it is more than or equal to 30%. Okay, what should be the ventility targets? Earlier they say 40 to 60, now they have removed it to 30 to 60. And what should be the initial peak inflation pressure? It should be like 25 centimeters of water, and they have divided also according to the gestation age also. So equal to or more than 32 weeks you are going to start with 25-30, and less than 32 is 25 20 to 25. Okay, now so you have given positive pressure ventilation, and how we are going to give this ventilation? We are going to ventilation by giving by MU bag, and there is something known as T-piece resuscitator. This is being very commonly asked as a spot diagnosis. So this is a T-piece resuscitation, and it is been recommended to be used for providing ventilation in a preterm baby. What is the helpfulness of this T-piece? It actually prevents the barotrauma. So sometimes in manual MO we can give excessive pressure that can lead to barotrauma. So in T-piece there is a measured PIP and PEEP that it is actually given. Okay, but the problem is that it is not available everywhere where a delivery is being conducted. So MO, okay, one thing that I want all MBBS students to remember from NRP is parts of MO. Okay, what are the parts of MO? So see, this is the mask. This is a mask. Then there is something known as, here there is something, a valve-like effect which opens when there is air comes from the inlet to the baby, but cannot enter from here to here. So this is a fish mouth valve which acts as a single way valve. Okay, it prevents the entry of the expiratory air into the MO. And this is the pop-up valve. What is the role of this valve? When we provide the excess pressure, then it works like the valve of the pressure cooker. So it's actually pop up and will release the excessive pressure, so prevent the barotrauma. Then this is the self-inflating part of this MO, and here this is the oxygen inlet. Here we are going to attach the oxygen to the oxygen supply, and this is the reservoir. Oxygen reservoir role is the increase the FiO2. Okay, now coming to this, so how we are going to give the MO to the baby? We are going to give the MO by a EC technique. What is EC technique? You see that someone has hold it in C, and this is the E, 3 fingers E to hold the jaw, and C is to hold the mask. Okay, then what is the adequately? The mask should not come out of the chin, and it should not cover the eyes only. So from chin to the bridge of the nose, the coverage is the adequate mask. Okay, so mask has two sizes, 0 we use for preterm, 1 we use for term. And what is the sequence of giving ventilation? It is squeeze 2 3, squeeze 2 3. Okay, now if after giving ventilation the heart rate is still less than 100, then what we are going to do? If heart rate is not increasing within 15 to 30 seconds of starting ventilation, and do not observe the chest movement. This is a change that they have given the time of frame also. If it is not like that, then we are going to do what? We are going to start the ventilative corrective steps. It is now they have also updated it also. And we are going to consider intubation or laryngeal mask and cardiac monitor. Okay, agar nahi hai aisa, then you are going to give the post resuscitation care, communicate with the family, and team briefing. So now coming to the ventilative corrective steps. So earlier the sequence was actually MRSOPA, MR-SOPA, but now they say that choose the step most likely to be helpful and prioritize the order based on assessment and clinical situation. Okay, we are going to choose whatever steps we think is going to be helpful to my baby. So M for mask readjustment, R for repositioning of the head and neck, S for suction, O for open mouth, P for increase the pressure, or A for the alternate airway. Now there is also change in the alternate airway. So alternate airway, you can either intubate the child or laryngeal mask. So earlier laryngeal mask was being recommended when positive pressure ventilation or intubation is not feasible or successful. Now they have used that laryngeal mask can be used as a primary device for ventilation instead of alternate airway when mask and intubation are unsuccessful. And regarding the intubation, they have also updated the ET tube size ET tube size. So what they have said, from less than 800 you are going to, or 22 25B, you are going to intubate with 2.0 or 2.5. okay, you can read this change in the ET tube size. Then now the depth of the ET insertion is also changed. So what they have said, so the depth of insertion should be calculated from the anterior edge of the baby's upper gum in the midline instead of the lip. So we are going to calculate the tip to gum instead of the lip to tip. Okay. Now laryngoscope size, many people ask, 00 is for extreme preterm, 0 is for preterm, and term 1 is for term. And then technique you are going to do this. So always hold the embu in your left hand, and from you are going to insert from the sideways, and you are going to retract the tongue. And one most important thing is that do not pressurize the upper gum, it will lead to injury of the teeth. Always the handle movement is always like this way, upwards and anterior. Okay. Now even after giving the ventilation and ventilator corrective steps, our heart rate is still less than 60. okay, what we are going to do now? So you are going to intubate, or you are going to give the laryngeal mask. Then we are going to start the chest compression. And how we are going to give the chest compression? Coordinate 3:1 with ventilation part, and start with 100% FiO2, and consider for UVC or intraosseous line. Let's see. Chest compression, how we are going to do chest compression? So you can see that chest compression is now being given by only two thumb technique. Two finger technique is now being not recommended during NRP. And the person who is going to give the chest compression has to stand on the head and side. So you can see that the person is standing on the head and side, and the person who is giving the ventilation is being standing nearby on the side. So what it actually provides, it provides the space for someone who is sitting here, and now he has the access to give the umbilical line or any access that he wants to have. Okay. Now two thumb technique from head end, ventilate from side, and 3:1 compression ratio. Chest compression to ventilation is 3:1. That means in 1 second, in 1 minute, you are going to give 90 chest compression and 30 breaths. And how is the sequence? 1 and 2 and 3 and breathe in. 1 and 2 and 3 and breathe in. Okay. What should be the adequate depth? The adequate depth is 1/3 of the AP diameter of the baby, and we are going to press this on the lower 1/3 of the sternum above the Ziphy sternum, not on the Ziphy sternum joint. And when we are starting the chest compression, we have to start with 100% FiO2 at 10 liters per minute and ventilate. Okay. Now if the heart rate is still less than 60, after giving the chest compression, if the heart rate is still less than 60, then what we are going to do? We are going to put the umbilical or the intraosseous line, and we are going to give the epinephrine every 3 to 5 minutes. Okay. If heart rate is less than 60, then we are considering hypovolemia pneumothorax. What it actually means, let's consider. Okay. One thing from UVC. So UVC in umbilical venous catheter, we are going to put 3.5 to 5 French catheter, and while putting UVC in the NRP, you are not supposed to reach to the IVC. You just have to insert 2 to 4 centimeter until a free flow of the blood is there. And then now coming to the most important topic, epinephrine. So you can see that the epinephrine is 1:1000 concentration, and it is actually 1 mg per ml of the solution. So epinephrine, which actually comes is 1:1000, and it is 1 mg per ml of vial. So we are going to take 1 ml of this vial, and we are going to dilate it with 5 ml NS. So we are going to make a concentration of 1:10,000, which actually means that 1 ml of epinephrine is having 0.1 mg of epinephrine. Then what is the dose of epinephrine? So this concentration we are going to give 0.2 ml per kg followed by 3 ml NS flush. Okay. It is being said 0.1 to 0.3, but to avoid the confusion, they have said कि 0.2 ml per kg is the dose, or 0.02 mg per kg is the dose if you see, है ना. Now, if even after giving epinephrine and you see that there is some signs of shock or there is any history of blood loss is there, then you are going to consider it because of the hypovolemia. So what you are going to give? You are going to give the NS bolus as 10 ml per kg over 5 to 10 minutes. And if you are seeing that there is decreased air entry or there is decreased chest rise on the unilateral side, then you can suspect pneumothorax. Then what in pneumothorax we are going to give? We are going to do something known as bedside transfusionation test, where there is an increased transfusionation if there is pneumothorax, and if it is positive, then it is said that you are going to do needle decompression. Do not wait for the X-ray, and you are going to put the ICT in the time. Okay, now if the heart rate is 0 even after 30 minutes of NRP, you are going to discontinue the resuscitation, and we are going to counsel the family, and last we are going to do the team briefing. Okay, so one thing that I want to tell you, that this ventilation part should be completed within the 1 minute, and then rest we are going to continue the cycle accordingly. I hope that I have tried to make this video as quick as possible to avoid the loss of the audience in the long video. You can read the NRP and you can use it as a notes in your time. Okay.